Morning. My topic is comparison of keratometric parameters from anterior segment OCT topographer and anterior segment OCT based biometry device keratoconus. My aim and objectives are to compare the anterior corneal keratometry values obtained from anterior segment OCT based topographer, that is Atlas Visandi OCT, and anterior segment OCT based biometry device, that is IOL Master 700 in keratoconus. My materials and methods are: it is done as cross-sectional study. It was done at Contrast Charitable Trust Eye Hospital with a population of 62 patients with keratoconus, and the time frame was 6 months. Inclusion criteria: patients coming to the OPD with keratoconus. Exclusion criteria include eyes with stromal scarring, history of corneal eye drops, history of corneal surgery including collagen cross-linking, and the patients having dry eye. The consent was obtained and detailed patient history was recorded. Basic ophthalmologic evaluations was performed. The consecutive corneal topography from Atlas Visandi OCT and the biometry from IOL Master 700 was done for keratometric readings. So these were measurements using both the machines. In the first machine, Visandi OCT, simulated steep K and flat K was taken from 3 mm and 4.5 mm area. And from the IOL Master 700, total TK1, TK2 and K1 and K2 were taken. And these were compared. Statistical analysis include the test of normality of these parameters was analyzed using Shapiro-Wilk test, which suggested that these parameters were not normally distributed. So hence, to compare between the individual parameters, Wilcoxon's sign rank test was utilized. The correlation between the keratometric values were done using Spearman's rank correlation, scatter plots, heat maps, and the agreement between methods was done using Bland-Altman analysis and rain cloud plot. Observations and results. The study analyzed the data from a total of 123 eyes of 62 patients. The mean age of the participants was 24.59 plus or minus 5.07 years, ranging from 18 to 35 years. The analysis of individual factors. The mean TK2 value from the IOL master was 49.54 plus or minus 4.55, while the corresponding value from the Atlas 4.5 steep K was slightly higher at 49.57 plus or minus 4.30. So a Wilcoxon sign rank test was confirmed that there was no statistically significant difference between these measurements. We can see that the p-value is more than 0.05, suggesting that the both modalities they provide comparable readings. Spearman's correlations also shows there was a strong positive correlation between all the variables, but very strong positive correlation was noted for 4.5 steep K and the DK2 value. Scatter plots also showed the strong relation between them, with more strong relation between the IOL master TK2 and Atlas 4.5 steep K values. Heat map, this also shows that there is a strong more correlation between the IOL master TK2 and Atlas 4.5 steep K. Bland-Altman analysis was performed separately for Atlas K and IOL master, and Atlas 4.5 K and IOL master, both for steep and flat K values. The mean difference on comparing these TK2 value from the IOL to the corresponding Atlas 4.5 steep K measurement was only 0.033, which shows that it is a narrower limit of agreement, suggesting that there is a stronger agreement between these readings. The first one is the Bland-Altman plot, and the second one is the rain cloud plot showing Atlas 4.5 steep K compared to IOL master TK2. My conclusions are: our study established that IOL master and Atlas topographer can be regarded as interchangeable for routine clinical assessments of corneal curvature, but strong agreement between the machines were observed for IOL master TK and Atlas 4.5 values. This findings holds considerable importance for the preoperative planning in refractive and cataract surgeries, providing clinicians with the flexibility to choose between these devices while ensuring accurate measurements. Limitations are: increasing the sample size could enhance the statistical analysis and improve the correlation between the two machines. When scanning larger areas, variations in values between the different machines may arise, potentially reducing the accuracy of the data. The difference in the values and correlations are more likely when measuring high refractive values, such as in cases involving severe astigmatism or actinic disorders. Recommendations are that test topographer and IOL Master 700 can be utilized interchangeably for clinical assessments of corneal curvature. However, the 4.5 mm central zone provides a more accurate representation of the corneal curvature. Machine learning techniques hold transformative potential in this domain. These are my references. Thank you.
One is always available, even with the general ophthalmologist. The IOL master is available even with the general ophthalmologist. The other is usually available with the cornea departments. So in that context, when we look at, I believe that trying to look at whether this is good or that is good, we can as well double check with both when you are going to intervene on these high astigmatic cases or keratoconus cases. Then these values are getting double checked by these two machines. Otherwise, there is no scope for changes in those measurements. What made you first to design these two machines as a comparative? Why did you want to compare these two machines? What made you think that when you compare two machines, it should be like either the principle by which the machine checks are different. For example, if I look at plateau iris patients and study UBM diagnosis of plateau iris and anterior segment OCT diagnosis of plateau iris, that is acceptable because they are working on different principles. But here I think that clarity is not there. It looks like a random comparison of two machines just because you had those two machines and you wanted to compare that data. That way it is good, but what implication it has to another person who listens to that study, I'm not sure.
Now I'm happy because at least one male candidate has come. Okay. Yes, sir. Yes, sir, Afrat. No.
Yeah, yes, sir. Yes, sir.
But there is no extra mark for that. Please remember this. The thing is what your slides, letters and all, no, actually PowerPoint is should be visible from this distance. Actually, I'm not able to see some of the letters, something very small size. Because the slides also carry marks. Preparation of slides and all carry marks. Then you told now Shaprowak test. Do you know what is that and all? In examination, suppose you are going to present a presentation and you will say as per Shaprowak test. Suppose I ask you, what do you mean by Dr. Shaprowak test? You must be able to explain.
It is done to uh, look for the distribution of the variable.
Please now, you can tell anything because I do not know about Shaprowak test. Please, it doesn't matter. Nothing wrong. At least in examination, be careful, okay? But examination, you cannot ask the examiner. You tell me, is it possible? Impossible to ask. Okay. When whatever you want to tell, before that you prepare yourself and go.
Okay.
Okay. Nice. Thank you, Ma.
Okay. Thank you.